Now, why did I decide to take some classes for you? I don't want to call it class. I want to call it to have a discussion with you on general anesthesia and especially inhalational anesthesia. Because right now the focus is going more and more towards regional anesthesia and blocks. Yes, it is quite safe, very safe to do it, provided you become an expert. And I suppose all of you will become an expert very shortly. And but what I find is that the basics of anesthesia are being forgotten when you start doing all cases safely under the block. And suddenly when you have to go and do a case under the general anesthesia, you are at loss. That is what I found when I made rounds in the theater in the last 2 weeks. When I just strolled into the theater, I found a lot of basic things that needs to be done when you give a general anesthesia are not being followed. So I said that it is time that somebody reminds you people of what are all the basics that should be maintained, that should be done. So I thought I will do a series of lecture demonstration or the lecture discussion series so that those things are highlighted. I assure you this is not going to help you in the exam. Okay, this is not going to help you in the exam, but it is going to help you in your life. That is precisely what it is. And we don't want you to, I don't want to prepare you for an exam. Exams will come and exams will go. But I want you to be prepared for facing the life for the next 50 years. Okay, that's the whole thing. So the first topic that I have chosen is to talk about the depth of anesthesia, the concepts and controversies. In all my lectures you will find I'll be backtracing the history to remind you these were the things that were done to become a better anesthetist today. So that it is, you get, and I want you to think on those lines, this has been done, so we are here, what we should do now to become better. That is what is the idea that should come into your mind. I want you people to start thinking, start analyzing, and start discussing. Without that, there is no point in doing a post-graduation. Okay, depth of anesthesia, concepts and controversies. Now you will find this lecture was prepared about 6 years back when I was not in the department, when I was in the department, not out of the department. So almost about 7 years back this is prepared, and it is still relevant. So I thought I will talk to you on this. Now this is a cartoon that was drawn about 7-8 years back. What kind of anesthesia can you afford? I mean, I just projecting it so that I suppose I can bring about a change in the attitude of people who are practicing anesthesia. This is not a joke. This happens when you go to a private practice and you decide on what to give depending on how much the patient can pay. Huh? And you tailor your anesthesia according to what payment the patient can give. That is one end of the spectrum. Other end of the spectrum, you have here. You people don't even look at the patient. You are engrossed in something else. What happens to the patient, you are not concerned about. These are the other end of the spectrum. Okay, so between the two, you will have to balance yourself to look at the patient and to give what is essential, what is required, and not overdose, not underdose on those lines. So, the objective of this lecture is to define the depth of anesthesia and define the target drug to reach these goals. That is what is the idea of this particular lecture. Well, how do you define anesthesia? Way back in 1937, Guedel staged the stages of anesthesia. So that's what he said. This what if it is there, then you have this depth of anesthesia. What is that? What are those steps? These are the 4 steps. Stage 1 is analgesia. Stage 2 is delirium. Stage 3 is surgical anesthesia. And stage 4 is medullary depression. At that particular time, we were using ether. We were using only ether and nitrous oxide. Chloroform was there, but it was slowly going out by that time. There is no other agent that has come. But nobody thought about how to say this patient is ready for putting the knife on the patient. So he sat down and recorded all the patient's vital signs. And then he said, this is there. Then the patient is adequately anesthetized. So then you can do a surgery. Do you people have any idea about what are all those physical signs that he looked at to say, yes, the patient is at this depth? Pupillary reflex, fine. What else? Depth of respiration, okay. Then? Anesthesia, stages of anesthesia. No. Anything else? So he decided all this, he defined all this. Most prominent thing is the respiration. I said the depth of respiration, rhythmic, equal thoraco-abdominal breathing is what denominates that the patient has gone into surgical anesthesia. Before that, you have varying patterns. It might be irregular, it might be regular in stage 2. That is one parameter. Other one is pupillary reflexes, you said. Pupillary reflexes were not looked at. It is reflex, if you look at it, it's eyelash and corneal reflexes that are seen. But pupillary size, progressively dilating pupils and moderately dilated pupils, and centrally fixed eyeball, that is another sign. Centrally fixed eyeball with a moderately dilated pupil. These were the signs. And of course, the swallowing, retching, vomiting reflexes are abolished. And glottic reflex gets abolished only a little later. So if you want to intubate, you will have to take this patient to this stage. And if you're not intubating, you can maintain the patient at that particular stage. That is how we defined. And then, of course, the muscle tone, which is progressively being reduced. So these are the signs. So when you want to say, yes, you start your surgery, you look at the pupils, you look at the respiration, and predominantly this pattern of respiration and the pupil, central fixation of the eyeball, if it is there, then you start your case. And taking them to these phases, stage 1, 2, and 3, plane 1, is a process which you try and shorten it so that the patient does not go through the stormy period. That is how it used to be. Now, at that time, we had the introduction of intravenous agents, especially thiopentone. Who introduced thiopentone? These are the questions likely to come in your exam, in your viva. Who introduced thiopentone into clinical practice? Almost about 80 years back. 80 or 90 years back. 1830. 1930. Into clinical practice. Who? You must know these names. Lundy. And simultaneously, other person who used it was? Who is the other person who used it? But the credit went to Lundy, but both of them used it simultaneously in different hospitals. Very famous name in anesthesia. Waters. Not drinking water. His name is Ralph Waters. Okay. These are the two people used. So we had the intravenous agents coming inside. So the main thing is you give an agent, within 30 seconds the patient is taken off to the surgical plane. So whatever stages that have been described by Guedel slowly went out of vogue because they made no sense when you started using intravenous agents. So those stages became true only for ether anesthesia, and when you use anything else other than ether, those stages, those classifications did not make any sense. Even when you started using other inhalational agents, these stages did not make any sense. So that has slowly gone out of vogue, and you people don't even look at the patient now when you anesthetize. Why is that? Because I'll tell you the reasons. Rees and Gray in 1950, they defined anesthesia as a triad of anesthesia, three components that needs to be satisfied. And what are these three components? At 1950, they said unconsciousness, analgesia, and relaxation. These are the three components of anesthesia which needs to be satisfied, and that is what it is. And what happened, this is in 1950, then what happened? We had introduction of muscle relaxants, 1954 to 62. We had succinylcholine, we had galamine, we had D-tubercularine, all of them came into the clinical practice. And so one component or one component of what they have described as relaxation was taken care of by this particular muscle relaxant. And so now, then what happened? They put up a concept of balanced anesthesia, and they redefined the anesthesia, the components of anesthesia in 1970, and that is narcosis, relaxation, and reflex suppression. So these are the three things that needs to be satisfied to say the patient is anesthetized satisfactorily. So this is what the definition given in 1970 by the Liverpool School. And and what they did, they extensively started using muscle relaxants. Why this muscle relaxants? What did it so? Because it can satisfy two components. One is relaxation, second one reflex suppression. So these two components are taken care of. And then the narcosis, they said nitrous oxide is a good agent. Then they used nitrous oxide at 75% and 25% oxygen. And the anesthesia used to be gas, oxygen, and relaxant. That is what the anesthesia that is used extensively by the Liverpool School. And when I went to Liverpool in 1987, that was the practice. Only nitrous oxide will be used, relaxant, gas, oxygen, and relaxant, and nitrous oxide up to 75% concentration. Okay. And what happened? The controversy that came on. Chris Roberts, he said in 1987, he said that anesthesia is a reversible state of consciousness, loss of consciousness. Neither perceives nor recalls a noxious stimulus. This is what he defined anesthesia as. Yes, this is what it is. Anesthesia is a reversible loss of consciousness where a person neither perceives nor recalls a noxious stimulus. That is what it is. If that is, then there is no variable depth, it is an all or none phenomenon. If you follow that, there is no variable depth of anesthesia. Either you are anesthetized or not anesthetized, only two states. And so it's an all or none phenomenon, and there is no variable depth of anesthesia. That's how he described. Whereas when you used ether, we defined different stages of anesthesia and said if you go into this is where you are, the depth of anesthesia. But here he said either you are anesthetized or you are not anesthetized. You don't differentiate depth of anesthesia by stages, especially when all these have come inside. Muscle relaxant, he said, is neither a component, neither a requirement nor a component of anesthesia. Yes, muscle relaxant is a requirement for surgery. It is not a component of anesthesia. You understand? You use a muscle relaxant to facilitate certain surgeries, especially abdominal, because you need a lot of relaxation of the abdominal muscles. But otherwise, all other surgeries, do you need a relaxant to be given? For thoracic surgery, do you need a relaxant? You don't need a muscle relaxation when you're doing that. When you're doing limbs and other things, do you need a relaxant? Then why has it been used as a component of anesthesia, abolishing a lot of other information that is needed to be monitored? So that's what it is. Then he said muscle relaxant is neither a requirement nor a component of anesthesia and should not be considered as a component and should not be included as part of it. So that is how the definition of anesthesia from 1937 to 1987 changed. There's a whole lot of change in that 50 years, and I have traveled through 35 years of that. Okay. Now, then you need a workable definition for anesthesia. Then what is the workable definition for anesthesia? Then there are a lot of studies that went on in the 80s and 90s to define what all needs to be done. What did they do? Define the endpoints. One group of people started working on demonstrating a relationship between the measurement, that is a movement of a patient, and the dose or concentration of the anesthetic agent that is needed to produce that particular state, and that is defined as MAC, minimal alveolar concentration. And then another group was working on show a relationship between the measurement, that is the level of consciousness, and the concentration of the anesthetic. The measurement is level of consciousness, so and that they labeled as MAC awake. And then show a relationship between measurement, that is adequacy of anesthesia, and concentration of the agent, and that they labeled it as MAC bar. What does that bar stand for? Yeah? Blocking of adrenergic responses. So that is MAC bar. These are the three different. Huh? Okay, and this is an editorial that came out in Canadian Journal of Anesthesia in 1991. Okay. Now, in 1993, then this is another turning point in the histories, exaggerated anesthetic requirement in preferentially anesthetized brain. That is by Antonioni. Yeah, what did he do? The goats, what they did is they cannulated the carotids and the jugulars and then perfused the brain preferentially when the body is being perfused by the heart. So and then they estimated what is the MAC level for isoflurane. And then also they took off and perfused the whole body completely and found out what is the MAC level. So what did they find? They found that MAC of isoflurane, preferentially perfused brain, it is 2.9 plus minus 7.7. When the whole body has been perfused, the MAC was 1.2 plus minus 0.3. What does it mean? The anesthesia immobility is not mediated right in the central nervous system on the brain, but it is at a different place. So you have site of action at different places. So they said different clinical endpoints are mediated at different sites anatomically, cellular level and receptor level. So you find that akinesia, that is inability to move, immobility is inhibition of movement to the noxious stimulus mediated at a spinal level, because they found the MAC level came down when the whole body is perfused. And so akinesia is mediated at the spinal level, and that's what you call as MAC. And then you have the amnesia and hypnosis that is mediated in the central nervous system, where there is a loss of response to verbal command controlled at supraspinal level, and then you call that a MAC awake. So this is how they defined the two things, two different endpoints, two different sites of action. And in 1957, we go back to the history again. 1957, how did they define? That time itself they said changing concepts concerning anesthesia, and that was by Woodbridge, Philip Woodbridge. How did he define at that particular time? He said 4 A's for defining anesthesia. One is analgesia, which is a sensory level. Then second one is akinesia, that's a motor component. Then the third A is autonomic reflex control, that is the third A. And the fourth A is amnesia and hypnosis, which is at a central level. So these are the 4 A's of anesthesia, but nobody paid any attention to this, and the progress is going on. And finally they went back and looked back, this is what has been defined by one person. And so right now, how do we define now? 1965, this man first report about minimal alveolar concentration, which is the standard of anesthetic potency, was published by this man. And after 50 years of research, this another article he wrote in 2006, after 50 years, more than 500 research publications analyzing the site of action. Who is this man? He said, anesthesia defined. Gentlemen, this is no humbug. Do you recollect these words? Gentlemen, this is no humbug. Who told this? Yeah? Yeah, who told it? Who's the surgeon? Who said it? He said, gentlemen, there is no humbug. So the same words he has repeated, it was told by Warren. Huh? And this is no humbug. This is the title of the article that he wrote in 2006. What did he say? He said, all inhaled anesthetics act on the central nervous system to produce two reversible components, condition, that is immobility and amnesia, and that define the anesthetic state. No other reversible, clinically useful conditions are essential for the definition. So all that you need is amnesia and immobility, and the other component, that is analgesia, is unmeasurable when the person is anesthetized, and no other condition define anesthesia, only immobility and amnesia supply such a definition. So he defined anesthesia as immobility and amnesia. These are the two components of anesthesia that need to be satisfied. So that is what. How do you produce immobility and how do you produce amnesia? Do you use a muscle relaxant? No, muscle relaxant is not a component of anesthesia. It is a requirement for surgery. So that is not to be used for producing this immobility. Okay, that's what it is. Eager, AD the two, Edmund Eager the two. This is what he's the man worked on this. Now in 2008 he wrote another article saying, is a new paradigm needed to explain how inhaled anesthetic produce immobility. Even after all that 50 years of research, especially on site of action and how it is produced, he is still doubtful. Do we have to look at another paradigm to see what is site of action, how the immobility is produced by these agents. So that is so. So look at analgesia. He said analgesia is unmeasurable, that is there inside. Analgesia, what it is? What is pain? You have a peripheral injury, You have a peripheral injury and then it is transmitted through the peripheral nerve, dorsal root ganglion, dorsal horn, ascending pathways and into the thalamus, and then it is projected onto the cortex. And you perceive the pain. Understand? And then there is a modulation, and then the descending modulation, and then there is a modification of what you perceive. So when you have a pain, if I prick you with a pin, suddenly you find there is a pain, and then even if I continue to prick it, you find that it is not producing pain. Because of descending modulation of the nervous system, it modulates whatever you perceive, and then the component of pain is not perceived anymore when you continue to press it. So that's what it's pain. Okay, what does it mean? Pain is, what is pain? Yeah. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This is a definition formulated by International Association of Study of Pain. That is way back in Bonica in 1979. So if this is the definition for pain, then what it is? If pain is conscious perception, and when your anesthesia is unconsciousness, pain is a conscious perception and anesthesia is unconsciousness. So where is the question of pain under anesthesia? Then there could be no pain during general anesthesia where the person is neither perceiving nor recalls a noxious stimulus. I am putting controversies into your mind so that you will start thinking. Okay. When general anesthesia, where a person neither perceives nor recalls a noxious stimulus, there is a question of pain. If pain is a conscious perception, sensory perception, that is what is a pain. Okay. Now, Conscious perception is not there under anesthesia, but autonomic reflex control, autonomic nervous system is quite active. Right? It is not dependent on consciousness. Autonomic nervous system acts separately. So when that is happening, the conscious perception and reaction is system independent of consciousness. It responds and needs to be suppressed when you anesthetize. How do you bring about that? That is why that MAC bar came, where you block the autonomic reflexes. It's termed as blockade of adrenergic response. That is how it is. Okay, let's confirm it from Google. Yeah, if that is so, what can regional block can definitely abolish this. Opioids can take care of analgesia as well as autonomic reflex control. Okay? That is why the component of regional anesthesia is coming in more and more, so to block at the site of surgery, to block the sensation so that autonomic nervous system is not activated to that extent, and so you carry on with the very stage of anesthesia can be much less than what it is. Now finally, what defines anesthesia? So what defines anesthesia is amnesia, which is MAC awake, and then akinesia or immobility, that is MAC. See, these are the two things that you will have to look at when you are anesthetizing a patient with a component, with an agent. Now, coming to the inhaled anesthetics, what is it? So, this is both amnesia and akinesia provided by one molecule. You start from ether, chloroform, whatever the inhalational agents that we have used. And finally, now we have landed up with sevoflurane and desflurane at that level. And both amnesia and akinesia is provided by one molecule. So if it is so, why should we use all other things? That is what is the percentage easily measured in the exhaled gases. You are looking at the entire value of those things. And then directly relates to clinically relevant endpoint, that is amnesia, which is MAC awake, and akinesia, that is MAC. So you have these values and you know where you have to be there. And that is what you will have to tailor the anesthesia to. Now when you do that, these are the articles that came in 2008. Awareness with recall during general anesthesia, prospective observational evaluation, 4,001 patients were studied. What did they find? They found that associated with awareness with recall, anesthetic technique, incidence of 1.1% when total intravenous anesthesia with relaxant was used. And it is 0.59% when balanced anesthesia was used. And it was 5% when nitrous oxide-based, oxygen nitrous oxide-based anesthesia was used. Even though you use 75% nitrous oxide, the incidence of awareness at recall is at 75%. That is what is the observation from this particular study. And you find there are a lot of articles that came out in 2008 addressing the problem of awareness under anesthesia, because the trend was slowly changing from inhalational anesthesia to total intravenous anesthesia with propofol. After it was introduced, propofol with a narcotic and a relaxant. That is what, instead of gas oxygen relaxant, it became propofol relaxant. And you had a lot of cases of awareness. Why did that happen? You look at the correlation between propofol and the level of consciousness. You find that this is the predicted level, with all the formula that have been put forward, this is the predicted level of propofol in the blood, and this is the measured level of propofol when they did the studies. And what is thing is, when you predict a level of 4, between 2 and 4 here, the measured level is less than 2. These are the group, you are not worried about when you predict 2 and it is 4, 6 or 8. You are not worried about those patients who are very adequately anesthetized. But you find here that when you are predicted between 2 and 4, it is less than 2. These are the patients who remain conscious, because you are giving a predicted level dose to produce a measured concentration of more than 2, but it is less than 2. And then you are using a relaxant on top of it and to produce immobility and facilitate surgery, then patients are fully, they perceive everything, they recall everything and narrate what's happened. That is how it has gone on. So from that time when we had awareness, when we switched over to gas oxygen relaxant and switched over to something, at that time and this time, the awareness levels were similar, the incidences were similar. So that's not the only thing. They measured the propofol level and then the BIS. BIS is an indicator of depth of anesthesia. What is BIS? Expansion? Bispectral index. Okay. Okay, so they measured that. So you find even with the between 2 and 4, you had patients who had a BIS of 80, which means they're conscious. But the measured propofol level is between 2 and 4. And that is what. And there's so much of variation. With just 2, the patients who are totally under anesthesia, according to BIS, between 40 and 60. And you had a group of patients where you had the BIS of 80. So if you are not monitoring that and bringing it down, you are subjecting one group of patients to awareness when you are using. So they said BIS should be used in all patients for monitoring depth of anesthesia, and no anesthesia should be given without monitoring the BIS or the entropy. That is what is the statement that came out. That is in 2010, 8-10 at that time. Now, if you look at the inhalational anesthetics, what is it? There's a steep on-off. So MAC awake is here, and then MAC defines immobility, MAC awake defines hypnosis. No, not the BIS. That is what the thing that was put forward in 2010. And because MAC level, the variation is less than 10 to 15% variability between the two, and there's a wide gap between MAC awake and MAC. MAC awake is 0.3% of the MAC. So you have a different, quite broad spectrum for maintaining a patient between these two. And where should you maintain it? Now, if you look at that article that is published in 2008 again, about anesthesia awareness and bispectral index. The BIS value is greater than 60 in one case of definitive anesthesia awareness. And end-tidal concentrations were less than 0.7 MAC in 3 cases. They recorded 4 patients who can have awareness with a recall. And this is the finding that they had. All patients were anesthetized or monitored using a BIS. And one group had end-tidal monitoring and other group had an intravenous anesthesia. Okay, so no, this is all patients had monitoring and both BIS and end-tidal thing, and then they differentiated with the BIS of this is what is the thing, and with the end-tidal of this. So finally they came to the conclusion, if the MAC is more than 0.7, then there is unlikely to be awareness, even though there is only BIS picked up only one case when it is more than 60. So what is a better monitoring? They said better monitoring is end-tidal concentration and not the BIS. If you can make sure that the end-tidal concentration is more than 0.7 MAC, then you are assured that there will be no awareness under the anesthesia. Then why should we use opioids? If all this, what is the role of opioids? Since inhaled anesthetic ensures both aspects of anesthesia, should we use narcotic at all? That is what is the thing. Yes, you do use narcotics. What the indication is to pre-eliminate post-operative pain. So under anesthesia, when you're unconscious, you don't perceive, but when you wake up, you start perceiving the pain, and that is going to be problematic. So when you use narcotics, you pre-eliminate the post-operative pain and decrease the MAC of the agent that you're using and facilitate autonomic control. Okay, that is That is why you use adjuncts like the opioids. How much opioids to use? You find these are the studies that have been done with fentanyl. You find the fentanyl concentration, as you increase the fentanyl concentration, the MAC value comes down. And similarly, this is for MAC, and this is for MAC bar. Okay, that's for MAC and this for MAC bar. But you find after a certain level, there's a plateauing, and any further increase in the administration of opioids does not decrease the MAC to any further level. So there is a ceiling effect. Yes, it brings down the MAC value to a large extent, but increasing it further and further, giving more and more of the narcotic is not going to reduce the requirement of the inhaled anesthetics. Why are we making this particular statement? This is for, there's a ceiling effect on the MAC, and so there's no point in increasing the amount of narcotic that you are giving, because there is no correlation between the MAC awake. Even at level of 2.5, the patient can be awake. The level of fentanyl is 2.5 nanograms per ml, and the target is about 1.5. And so patients do wake up whatever is the level of thing, and there is no correlation between the MAC awake and the level of narcotic in the blood. So it does not have an effect on the wakefulness. So it does have a ceiling effect. It does not reduce the MAC, the requirement of inhaled anesthetic to a large extent. So you can use it, but no point in saying that I will give a total narcotic anesthesia and I will not use anything. I will use only the. There was one phase at a time when only narcotics were used to give anesthesia, narcotics and relaxants, especially for open cardiac surgeries. And they said no, patients are well maintained, hemodynamically well maintained, but at the cost of awareness. Okay. So then how much narcotics to give? It is not just a small dose you give. You should give an adequate dose that reduces the MAC, but not overdose it. Do not use enough of inhaled agents even when you are using. And the narcotics have only a ceiling effect, so you cannot reduce the MAC any further. And too little agent will lead to awareness. So in a non-paralyzed patient who does not move, is receiving a potent inhaled anesthetic, there is no risk of awareness. How was this conclusion made? It was made from the ASA closed claim study analysis. What is that ASA? American Society of Anesthesiologists. Closed claims is that all those patients who have filed suits and then had a case going on, it didn't go to the court, it has been settled out of court. And all those cases were analyzed by the insurance companies. And then this statement was made, patients who are non-paralyzed, who does not move, do not have awareness. That is what is the final conclusion by analyzing all those cases which have been settled out of court. Now, why is that so? It's because I told you this is MAC awake, and then this is MAC, and there is no patient like this where the patient is still conscious and immobile. There is no patient, there is no crossover of these. There is no patient where on this line where the patient is conscious and then immobile when you are used to single inhalational anesthetic. So you find this is an article published in 1998. What they concluded is that if I give more than one MAC, then surgical incision, then the patients do not have a recall. You find that patient has moved, 19 patients have moved at tracheal intubation, 10 patients here, skin incision, but recall of the incident was not there in none of them. Okay, but does it mean that we have to allow this? This is, you find there's increase in the heart rate for about 30%, there's increase in blood pressure by 30%. When they have done that, even though there is no recall, should we allow this to continue? We should not be. We should be having a control on all this also when you are putting a tube inside or when you are doing a case. So, I I can give opioid to reduce the MAC, I can use muscle relaxant to ensure immobility, but how much should I use? How much of inhaled anesthetic is needed? Just remember, ED50, hypnosis is MAC awake is 0.35 of MAC for most of the agents. And if you go to ED hypnosis 99.9, instead of 50, you go to 99%. So what is that level? So if you go and use double the MAC awake, then you are making sure you have a big window for avoiding awareness under anesthesia. So that should be the target to reach, that twice the MAC awake if you can maintain. Then that should be sufficient anesthesia when you are using relaxants, when you are using blockade and other things. So even those times you should use minimum of this to prevent an awareness. See, you can put a tube, I want them only to sleep, and so I reduce my inhaled anesthetics and continue with that. Yes, that can be done, but make sure that they don't have an awareness, even if you are doing the case under a block. Unless you explicitly told the patient that you are going to be awake, I am only going to put you to sleep. You might hear some voices in between, you might, but you will not have pain. If that kind of a conversation has gone on with the patient before you start your case, there is likely to be a case, if you are not explained, you are doing the case under regional and sedated them and put a tube to maintain a little bit of unconsciousness, and patients feels and receives a lot of things, then still they can make a complaint. Saying that I was totally aware of what was going on in the theater and I have been told that I have been anesthetized, though I did not feel pain. The awareness recall is not about pain. Awareness with recall is recalling whatever the incidents that is going on, that is what it is. So even if you are doing under regional, explain to the patient this is what to expect and this is not to expect this. So incidence of awareness is vanishingly small if MAC is more than 0.5. That is what, again, Edmund Eger, this too, he told in 2005. End-tidal concentration of less than 0.7 MAC in 3 cases of definitive awareness. So that's why we said, if you can maintain more than that level, then it is sufficient to prevent awareness, and you have taken care of all other things by other things. So this is what you should aim at. This is what you should be targeting and tailoring your anesthesia to. What should be the target? Instead of giving that dose that might ensure hypnosis in most patients, that is, you give a dose which ensures hypnosis in all patients. That means you reach a level twice MAC awake. That is what should be the target that you want to reach when you give. Why can't we go above that? If you go and use a dose which is much above that, you are just wasting the agent, and the cost for the patient is going to go up. Provided you have taken care of other components of anesthesia by using a block, by using narcotics, by using adjuvants, whatever it is, you have taken care of all other things, then this much is enough. What about nitrous oxide? What's the time? What about nitrous oxide? Yes, it's a very useful agent. All of us use it. All of us use it quite extensively because I did not ban it. Okay. There are institutes there where people have said, no, we are not going to use nitrous oxide, and you don't have a nitrous oxide to be used. That is what it is. Because I have not banned it here, you are continuing to use the nitrous oxide. Am I right? Yeah. So, but what I do not proportionately reduce the percent of my potent inhaled agent, because, see, usually the machines give you nitrous oxide MAC awake is 0.52 to 0.59 when you use 60 to 66% of nitrous oxide. And if this is 0.5 MAC, and then if I use inhaled agent and then take it up to 0.7, 0.8 MAC, that means I am using a very little of inhaled agent. Is that enough? All the machines will give you an addition, total addition of calculating MAC for nitrous oxide and calculating the MAC for inhaled agent, and put them together. 0.5 plus 0.4, MAC is 0.9. 0.5 plus 0.5, it is 1. So it is not so. If you look at all the studies that have been done, MAC awake reduction is not linear when you're using nitrous oxide, so you have to be careful. This is the study which shows the relationship between the percentage of nitrous oxide and percentage of sevoflurane that is needed. It is not a straight line, it is a parabolic line. It's a line like that. So if you just say that I am here or I am here, this line is extrapolated like that, or this line is extrapolated like that, then if you keep the patient here, then you are likely to make a mistake. So I do not take 1 plus 1 as 2 because of this property of nitrous oxide. It is 1 plus 1 is 0.9, 1 plus 1 is 1.8. That is how the calculation will come. So 0.5 of nitrous oxide and 0.5 of the agent together does not make it 1. So it is less than that. That you should always keep in mind, because all our monitors do a linear calculation and then say and show you the MAC values. So what should be? So I don't know, I find that in the last 4 years this agent has gone out of your practice. Nobody seems to be using this. It's a very useful agent, and I struggled to get this inside for 5 years, 2005 to 2010. I struggled so much to get this agent inside so that I can cut down on the halothane. And now I find this is not being used, and what is being used is other agents, sevoflurane and desflurane. We'll talk about that in the next 2 classes sometime. Now, what is the target if you're using isoflurane? If you're using oxygen and air, then alveolar concentration should be between 1.1 to 1.4. That makes it more than 0.7 MAC for isoflurane, because when you are using air only, then you have to maintain a concentration equivalent to that. And if you're using, along with nitrous oxide, then the alveolar end-tidal concentration of 0.7 is enough to give you a depth of anesthesia. And if you're using sevoflurane, what should be the thing? If you're using it with air and an opioid, then it should be maintained between 1.5 to 2% if you are not using nitrous oxide. And if you use nitrous oxide, then it could be brought down to 1.3. That will be around twice the amount of 2 times the MAC awake, 0.7 to 1.4. Okay, that is what is needed, provided you are using additional opioids, or if you are using a block or whatever it is, so which cuts down the reflexes to a large extent. So to conclude, depth of anesthesia is well defined now as amnesia, that is equivalent to MAC awake, and akinesia, which is MAC. So you have to maintain, according to the requirement of surgery, you have to maintain whatever level that you need, but autonomic reflexes should be abolished, and muscle relaxant is not a component. Use an adequate inhalational anesthesia to produce akinesia. Or combine with regional block whenever it is possible, so that you can bring down, this produces immobility. For that part, you might find suddenly that surgery is going on, the patient might lift the hand and try to take out your tube. That also, so those are the things. So use an adequate inhalational agent to produce akinesia if it is indicated, and combine it to regional block and narcotics to reduce the amount that is needed to produce that akinesia. And muscle relaxant is not a component of anesthesia. Okay, so with that I conclude. I suppose I had put some controversies in your mind, something to think about, something to talk about. Please talk about this within your groups. Have some controversies and get them clarified with your consultants.